Good morning, everyone. Happy to be here for my last Grand Rounds talk of residency, which is crazy. But today I'd like to talk about my global ophthalmology experience in Tanzania from this past September. Oh, thank you. Perfect. When I got back from my trip, a lot of my co-residents expressed interest in wanting to learn more about the international ophthalmology opportunities that we have at Moran. And specifically, they were interested in knowing what those opportunities are like for residents. So I'm hoping that this talk can give a little bit more perspective from my personal experience. And I'll just say that from the get-go, global ophthalmology is a huge topic, and we could probably spend hours or even days talking about all of the nuances and challenges associated with global ophthalmology. So this brief talk is really only going to be scratching the surface in order to give a little bit more context to the residents that are interested. Okay, there we go. I have no conflicts of interest to disclose. And here's an overview of what I'll cover today. So first I'll talk about my 2-week experience in Tanzania. I'll highlight some of the work we did there and specifically how I was able to get involved as a resident. I'll then talk about some of the challenges with global ophthalmology that I noticed during my trip, as illustrated by a tough clinical case that we had there. And then I'll discuss some of the key learning points that I've thought about while I was on that trip and since I've returned. And I've summarized those as the 5 R's of global ophthalmology. This is a general breakdown of my schedule and how I spent my 2 weeks in Tanzania, which I'll talk about in more detail in a little bit. But during the first week, I got to work with 3 glaucoma specialists, Rachel Simpson, who we all know, Brad Hansen, and Tripper Sauer. And this week was really focused on helping to train 3 Tanzanian glaucoma fellows that Moran is partnered with. And then during my second week, I got to continue working with the local Tanzanian ophthalmologists, as well as Paul Israelson, one of our global ophthalmology fellows this year. The city I was based in is called Mwanza, located in the northwestern part of Tanzania along the shore of Lake Victoria. And Mwanza is actually the 2nd largest city in Tanzania. There's like over 3 million people living within the Mwanza region itself. And the primary language in Mwanza and Tanzania as a whole is Swahili. The institution that we worked in every day is called Bugando Medical Center, and Bugando serves as the tertiary referral hospital for people living within the lake and western regions of Tanzania, which includes a massive catchment population of like over 10 million people. Bugando has its own eye department building, which is shown in the photo on the right here, and the eye building includes inpatient beds where pediatric and adult patients can stay the night after their eye surgeries, and then there's also clinic and operating room space. So my first week at Bugando, as I mentioned, was a big glaucoma week, which as someone who was like actively in the process of applying to glaucoma fellowship at the time was really exciting for me. But during that first week, our main focus was really to provide clinical and surgical glaucoma education for the Tanzanian glaucoma fellows. Their names are James, Nuru, and Frank. They're shown in that picture on the right. And just for context, all 3 glaucoma fellows had previously received some training with Dr. Chaya and other Moran affiliates before this trip. So all of them had some experience with surgeries like trabeculectomies, tube shunt placements, and some MIGS procedures before we arrived. Our visit was part of their ongoing glaucoma fellowship to help them become better equipped to care for the many glaucoma patients that come to Bugando for treatment. So as part of this educational experience, I got to give a lecture on the Advanced Glaucoma Intervention Study, or the AEGIS trial, which is one of the major landmark studies in glaucoma. I also helped lead a discussion on interpreting tricky non-glaucomatous visual fields. And the experience of preparing and presenting an educational talk or a lecture, I think, was really valuable for me as a resident. And helped to validate a lot of my own interests in academic ophthalmology. So I think for any residents or trainees who are interested in like practicing or learning more about giving an educational talk, this was a really great opportunity to do so. So we started off that first week by working in the clinic alongside the glaucoma fellows to help see glaucoma patients and sign patients up for surgery that week. And shown on the right here is a view of one of the clinic rooms, which just as a side note would get extremely hot and humid. So those big windows, having those open was really nice to get a breeze in while we were seeing patients. But as a resident in glaucoma clinic, I got to help see and diagnose a variety of different eye conditions, including things like neovascular glaucoma, tube erosions, non-glaucomatous optic neuropathy. And I also got to just help provide teaching points and clinical guidance whenever necessary. So as an example, on the left here is Nuru, one of the glaucoma fellows, and we were able to kind of walk her through how to do a tricky AC tap in clinic for the first time. Sorry, I think it's frozen. Okay. After that initial clinic day, the next 3 days were spent in the operating room. And the eye department at Bugando has 2 operating rooms with a total of 3 OR beds, which allowed each of the 3 glaucoma specialists to work one-on-one with the glaucoma fellows while they were there. The main surgeries we focused on that week included things like tube shunt placements and tube revisions, trabs, some MIGS procedures, and also phacos. And as a side note for the residents, because this is something that I didn't really know before going there, the ophthalmologists at Bugando are very well trained in manual small incision cataract surgery, but they have pretty little training on phacoemulsification. So that was also a big part of their surgical training that week as well. As the resident on the team, I played a primarily organizational role in the OR that week. So I would help to assist really wherever I was needed so that the OR days could run a little more smoothly. And this included doing things like setting up operating microscopes, which I'll talk about that later, but grabbing supplies for surgeons, helping to train OR nurses on how to prepare medications, like mixing intravitreal antibiotics, preparing vitreous stain, things like that. And also keeping track of our stock of glaucoma devices and surgical instruments. Sorry, this is doing things against my will. Okay. Yeah, and the nice thing about being in the OR in this role as a resident is that throughout the day, I really got to float between all of the different OR beds. And so I got really good exposure to pretty much all of the surgeries that were happening that week. And this did help familiarize me with some of the different techniques or instruments that were being used there, like the Simcoe irrigation aspiration unit or the Ortley phaco machine, which were things that I had just not been exposed to before going to Tanzania. And then the following morning after each OR day, we would work with the glaucoma fellows to see all of the post-ops from the day before. And I really enjoyed these post-op mornings because it was an opportunity not only for the glaucoma fellows to see all of the patients they'd operated on, but it was just a nice opportunity where all of us were together in one room and fellows had the opportunity to ask questions and learn from the glaucoma specialists that were there. And as a little intermission, after that big glaucoma week, Dr. Simpson, Dr. Sauer, and I went on a really incredible safari weekend in the Serengeti National Park. We saw tons of incredible wildlife. These are just some photos I took with my iPhone. Dr. Simpson has like National Geographic level photography if you're interested in seeing those. And then during my second week in Tanzania, I got to continue working in the OR with various different Bugando ophthalmologists and with Paul, our global fellow. So just as some examples, I was able to complete a phaco with the Ortley machine for the first time, which is a very different experience than the phaco machines that we use here. And I think that'll be valuable experience for any future outreach trips that I go on. I also got to learn the steps of small incision cataract surgery by working a lot with Paul and with the other ophthalmologists at Bugando. And then during one of my OR days, this was really fun and interesting for me. So Nuru, one of the glaucoma fellows, taught me how to do lid averting surgery to treat trachoma, which is something that we just don't see as often in the United States. So it was just really interesting and fun to be able to exchange surgical ideas and knowledge based on our very different sets of experiences. Now, anyone here who's been involved in global ophthalmology or outreach trips, which I know a few of you have, I'm sure you're all aware that there are a lot of challenges with practicing ophthalmology in a lower resource setting like this, especially when there are maybe language or cultural barriers. And as I mentioned in the beginning, this talk is really only scratching the surface on some of those challenges. But what I'd like to do next is just briefly discuss a tough patient case that we had during my time in Tanzania and talk about how this case illustrates some of the challenges that you might face if you become involved in global ophthalmology work in the future. So this case is of an 18-month-old girl with a reported history of congenital cataract in her right eye, but a completely unknown birth or maternal history. In May of this year, she underwent cataract surgery with posterior capsulotomy of the right eye, and then was unfortunately lost to follow-up for multiple months. And during that time, she was supposedly being given prednisolone drops every 2 hours in that eye. So when she finally returned in July, her right eye was painful, red, tearing, and had an IOP in the 50s. So her steroid drops were tapered by the Bugando ophthalmologist due to concern for possible steroid response, and glaucoma drops and Diamox were started. She then returned about a month later with an IOP in the 40s, and her exam at that time was difficult, but there was some concern by the Bugando ophthalmologist that there was maybe some anterior chamber cell, maybe kind of a hazy appearance of the IOL. So at that time, they restarted the steroid drops in an attempt to treat that suspected inflammation. So when we arrived in September, the patient's IOP was still 43, and bedside exam showed a diffuse hazy plaque on the anterior and posterior surface of the IOL with no posterior view. And as you can imagine, one of our major concerns was some kind of longstanding infection that was causing these findings. So we took the patient to the OR, removed the lens and the capsule, performed a vitreous tap and a goniotomy. And with the lens removed, we saw that the retina was just covered with diffuse retinal whitening and hemorrhages, again, concerning for some type of infection potentially. So we treated the eye with intravitreal vancomycin and ceftazidime, but there were no antifungal or antiviral medications available for intravitreal treatment at that time. After surgery, the patient was started on oral antivirals in addition to topical antibiotics and steroids. And by post-op week 1, her IOP had improved to 12. And bacterial cultures from the vitreous tap were negative, but unfortunately, fungal cultures were not possible to test for at their facility, nor was something like viral PCR testing, things like that. And so the etiology of this patient's vision loss is still pretty unclear. And Paul updated me that the last time this patient was seen, the inflammation was supposedly minimal and the IOP was controlled. But due to this patient's substantial retinal damage already, she really has very poor visual prognosis in this eye. And there are many different challenges that we could focus on from that case, but I'm just going to highlight 3 here. So first of all, delayed presentation to clinic. In other words, a delay between the onset of symptoms and diagnosis is a massive issue in countries like Tanzania and other lower resource countries where things like transportation and access to medical care is pretty limited. Actually, a study I was involved with in medical school looked at delayed presentation in retinoblastoma patients internationally. And we found that lower income settings and also increased distance between a patient's home and the treatment center are, as you would expect, significantly associated with delays in presentation. But delays in initial presentation aren't the only issue. Consistent follow-up after diagnosis is also a major difficulty in settings like Mwanza, where patients may not have reliable access to transportation or passable roads. And this follow-up limitation might really force you to rethink your treatment plans in this setting, especially if you're planning to do a surgery that requires a lot of follow-up, like a trabeculectomy, for example. And finally, in lower income countries, there are also other limitations in diagnostic and treatment resources. And like I mentioned in this case, we didn't have access to things like fungal cultures or viral PCR. And like half of the typical intravitreal medications that we would have treated this patient with just weren't available to us. So working in this setting really forces you to rely heavily on your clinical knowledge and your exam skills to diagnose patients, and also might require you to be creative or think outside the box when it comes to managing diseases as best as possible. Before we end, I'll just close by summarizing what I've called the 5 R's of global ophthalmology, and I've listed those 5 things here. I want to recognize that successful and sustainable global outreach is a really complex endeavor. And this is by no means meant to be an oversimplification of this topic, but instead, this is kind of just a summary of some of the key points that I thought about and journaled about while I was in Tanzania. And I'm hoping that it can be helpful to the residents listening to this talk as well. So the first is resourcefulness. And as I mentioned a moment ago, sometimes resource limitations at international sites will really force you to be creative and find unique ways to overcome difficulties. And these photos illustrate just some examples of that type of resourcefulness. So on the left here is Brad Hansen, who noticed during a prior trip that staff were having difficulty keeping track of patients throughout the pre-op and surgical and post-op process. So he developed a system where patients are given a lanyard with their name and surgical information on it so that patients could keep that information with them for the entirety of their stay at Bugando. And then the other photos here, and why Dr. Simpson was laughing earlier, is because my arch nemesis of this trip was an operating scope that was missing a piece of equipment. We were trying to set it up and get it to work so that observers could also watch these surgeries. So the photo on the right here is me and Salome, one of the OR nurses, celebrating after we finally jerry-rigged a solution. Second point is rapport, and I really can't emphasize this one enough, but developing rapport or a mutual sense of respect with both patients and with staff is so important for optimizing trust and communication within the team. And even though there are many cultural and language differences between our Moran team and the Bugando team, this sense of rapport that's been established long before I visited Tanzania has really allowed our team and the Bugando team to work together with a shared goal of helping patients. Third is reciprocity, which basically means the mutual exchange of knowledge and skills for the benefit of both parties. So as I mentioned earlier in this talk, even though I was able to help provide some glaucoma education and learning points to the fellows there, really the ophthalmologists at Bugando taught me a ton in terms of how they perform surgeries that I've never seen before, how to deal with the challenges of limited patient follow-up or things like medication shortages. And we all have really unique clinical and life experiences. So that means that we all have different strengths and lessons that we can share with each other as well. Number 4 is relationships, which really goes hand in hand with rapport, but successful and sustainable global outreach really hinges on being able to develop those long-term partnerships with international sites. And one of the most meaningful parts really of this trip for me was getting to become friends with the nurses and the staff there. I think that's a really important component of any kind of global ophthalmology work. And then last but not least is repetition. And what I mean by that is that these partnerships or relationships are not meant to be isolated to a single trip or point in time. Ideally, these partnerships should be longitudinal with opportunities for ongoing mentorship and education. And like I said earlier, my trip was only one of many trips where glaucoma specialists like Dr. Brett's shown in this second photo have visited Bugando to share their knowledge with the glaucoma fellows. And we even have an ongoing and a growing forum for virtual mentorship and advice on WhatsApp where the Bugando fellows can talk with the Moran affiliated specialists for clinical or surgical advice anytime. So hopefully this summary was somewhat helpful to any of the residents or trainees who are interested in participating in an international ophthalmology experience in the future. I just wanted to close with the Moran Eye Center vision, which is kind of the shared goal, not just of our institution, but also our partners in Bugando, which is that no person with a blinding condition, eye disease, or visual impairment should be without hope, understanding, and treatment. Thanks to Dr. Chaya and the outreach team who supported my trip, Rachel Simpson for being an awesome travel companion that first week, and also Jeff Petty, who really encouraged me to journal and think about these learning points while I was there. And not sure how much time we have for questions, but if anyone has one or two, happy to answer those now.
Thanks, Ashley, for this lovely presentation. Next up, we have Dr. Nnana Amakiri, who's also one of our stellar PGY4 residents here at the Moran. And Nnana's presentation is entitled The Heart of Healthcare, a Blueprint for a Culture of Kindness. And Nnana's most adventurous thing he's ever done, believe it or not, was trying tikka masala for the first time last year in Salt Lake City.
What can I say? I'm an incredibly adventurous person, as you can all attest to. Thank you, Ashley. Thank you, Nadine, for the introduction. Ashley, thank you for your presentation. I'm excited to go to Tanzania in a couple of months myself, and you quadrupled my excitement, so I really appreciate it. So yes, my presentation today is going to really be exploring our culture here at the Moran, with hopes of providing a better understanding of how we can implement this culture anywhere we go, and of course, how we can sustain it as much as possible and possibly even improve it. Before I begin, I wanted to express my deep felt gratitude to really everyone who's been a part of my experience the last 4 years. I feel like you guys are incredibly dedicated to your work, gracious with your energy and your joy, and that really resonates from attendings, residents, but really, I think what resonates most deeply for me is the staff. You guys make coming in to work every day truly a blessing, so thank you so much. So this is the overview of what I'm going to go over, my motivation for the talk, just going over a day here and workplace culture in general, and then some literature I pulled up that kind of supports and challenges some of the conclusions I'm going to attempt to make, and then hopefully an open discussion. So I'll start with a short poem by Rudy Francisco, one that's always resonated with me. He writes, "The first step is a stir of bravery, a creation in bloom, a genesis, a birth. The scariest thing I've ever done is begin." To begin is both, I think, terrifying and beautiful, a truth I've come to understand through my family, the journeys of my family, my patients, my friends, my co-residents, and myself. Today, I hope to explore how the beginnings and our kindness can intersect. The idea of always beginning is deeply personal to me. My family's journey started in Nigeria, where my parents tested their resolve after the Biafran War, a civil war that ended in the 1970s that claimed about over 1 million lives. My parents and I are of the Igbo tribe, a people who were marginalized in the aftermath. Despite these hardships, they began anew with unwavering determination, planting seeds of hope and ambition that continue through me and my siblings. Like many in medicine, my own journey has been defined by driving around a lot, moving from state to state in pursuit of education and opportunity. My parents' ambitions for my siblings and I set the foundation, but along the way, I feel like I discovered my own through a lot of the people I've met all around the country. For me, it was a simple yet profound desire to make others smile. It's a small act, but one that carries immeasurable weight. I believe it's why I'm in ophthalmology today. It's why I'm in medicine, and I think it's why I'm in Utah as well. Believe it or not, this was me as a child in the middle, the kid with a very, very exceptionally large head. I wasn't exactly known for my cheerful demeanor at the time. My mother would often remind me of the power of a smile, how it requires such little energy, but really has the potential to brighten someone else's day. At the Moran, smiles are ever present. These smiles represent more than just good customer service. They are symbols of trust, of kindness, of connection, values that I believe are at the heart of healthcare. Well, that leads to my next point. Thank you so much. Whether it's Nestor smiling before giving me a well-earned ticket, or Gino and Ethan providing Friday night energy as soon as you walk in on a brisk Monday morning. Or maybe it's Kelly as you exit the elevator on the 5th floor, who reminds you of how despite how horrendous call was, it is truly such a gift to be alive. Or Chandler and Megan popping their head into the resident room frequently to check in on you while somehow also carrying the weight of the whole residency on their shoulders. Or in the middle of the night, you're surrounded by staff generous enough with their time and their energy to smile at you every single time you say hello. Again, we are truly so lucky. And why is this all important? Because how we spend our days, what we focus on, where we work, and the environments we create ultimately shapes our lives. This realization highlights the profound responsibility we have to make our workplaces more than just places to complete tasks. I believe they should be places that nurture, that inspire, and that are filled with love. And if you don't believe Pulitzer Prize winner Dr. Annie Dillard, take it from the Journal of Business, who published this illustration that shows how we spend our lives over the course of time. They say that we spend about a third of our time at work, truly a sombering truth. While I couldn't find healthcare specific data, I imagine the numbers would be even more staggering. I think this really underscores the urgency of fostering healthy, happy work environments. While I lack comprehensive data on whether or not residents and staff here are truly happier than average, my own experiences and the stories I've gathered from others provide a framework to support this notion. During my interview trail for fellowship, I visited various programs, talked to residents at different institutions, shadowed various clinics and ORs, and I really felt an energy difference. And I think this really ignited my desire to talk to you guys all about this today. The chart before you shows resident satisfaction scores from over the last 2 years. Highlighted by the red oval, our program mean is marked by the blue triangle and the national mean by the yellow triangle. This data shows that we definitely perform very well. It's definitely still have room to grow as well. At the University of Utah, attendings are surveyed in all specialties. Of the 18 specialties surveyed here, ophthalmology was tied for number 3 when surveyed on well-being, number 3 when surveyed on being energized or not burnt out, and number 7 when surveyed on employees feeling a sense of belonging this past year. Again, overall, we continue to do pretty well. I think a culture of kindness is defined by support, appreciation, and open communication among staff. These values directly influence employee satisfaction, which in turn impacts teamwork, patient care, and overall departmental success. I really like this illustration because it really shows how your energy, your attitude affects mine, my energy, my attitude can really affect yours. In an article by Oswald, Proto, and Scroy from the University of Chicago Journal of Economics, they argue that a thriving work culture isn't just a nice to have, it's essential for everyone's well-being. They showed that happiness can improve productivity by approximately 12% in experiments with randomly selected individuals made happier. Conversely, they show that lower happiness like bereavement or family illness correlates with lower productivity. I think this data underscores the importance of employee well-being in driving not only personal performance, but also overall success of healthcare teams. And honestly, I was questioning the results of this study in general, just because how can you really do experimentation on making people happier? And so that led me to further exploration. I think a study by Dr. Sakura and Kabeza also showed that Happy affect correlates with increased productivity and relationship building, independent of interpersonal power dynamics. And to double down on productivity, they looked at memory via functional MRIs. Their studies showed that positive expressions like smiling strengthen functional connectivity between the orbital frontal cortex and the hippocampus. They saw that smiling enhances memory encoding and retrieval by activating these key brain regions. And I also just love this photograph. So to summarize, the benefits of high employee morale include, but are not limited to, high patient satisfaction, better communication and support among staff, enhanced team productivity, and cognitive benefits. However, I think maintaining such a culture isn't without challenges. Barriers include, but are not limited to, simply identifying these barriers, communication gaps, resource limitations, and of course, burnout. Strategies for improvement involve targeted leadership efforts, consistent recognition, and fostering a safe space for feedback. Leadership plays a crucial role in ensuring these systems stay intact. I've highlighted several key factors contributing to establishing and maintaining this culture at the Moran with the help of several faculty members here in the next several slides. This includes open communication again, recognition of efforts, teamwork, financial incentives, and strong cultural values. It seems a diverse array is quintessential for targeting our diverse human desires that ultimately influences our happiness. For example, Dr. Olson emphasized the importance of addressing faculty needs, admitting mistakes, and constantly striving for improvement. Our Faculty Affairs initiative, led by Dr. Lin, is a prime example of leadership making tangible strides to nurture this culture. Through this initiative, faculty have an opportunity to reach out without any issue of being able to express their concerns. A particular quote I loved in our discussion was his emphasis on the fact that you don't always have to get it right, but you do need to try. Barbara Cruz shared with me specific examples of how we recognize efforts at the Moran. Here, recognizing and celebrating the exceptional efforts of staff is a longstanding and integral part of the Moran culture. Management teams dedicate time during meetings to highlight employees who have gone above and beyond, fostering an environment of appreciation and motivation. A personalized touch can be added through handwritten notes sent to employees' home, allowing their families to share in the acknowledgement of their hard work. Additionally, standout individual awards are honored with the I Made It Happen, where they select Moran-branded items and receive recognition from leadership in a formal presentation. Over the years, the hospital has implemented various programs to emphasize the importance of employee recognition. In the early 2000s, the hospital embraced principles from the Good to Great initiative by Quint Studer, focusing on the idea that staff can never underestimate the difference that they personally can make. These principles continue to shape Moran's culture. Programs such as the Circle of Excellence, which began a decade ago, further underscores a commitment by celebrating employees with an annual recognition dinner, where managers deliver speeches highlighting their contributions. From newsletters in the 1990s to tailored recognition initiatives across departments today, Moran's dedication to acknowledging employee achievements remains central to its success. The Way to Go Awards are an example of how we celebrate those who go above and beyond. From peer recognition to spontaneous acknowledgments like gift cards, or team lunches, these initiatives foster a sense of appreciation. Holiday recognition like luncheons or gifts also plays a big role in strengthening morale. When I talked to Brandon Cresswell, he acknowledged that annual incentives have potential, but they can be further structured to really increase engagement that's currently present. I think this quote encapsulates why we strive for a culture of kindness. In his book, Secret Service, John DeJulius writes, "Something significant happens to a person when they feel cared for. They may not realize it at the time, but they want that feeling again." When people feel cared for, whether staff or patients, it creates a cycle of positivity that strengthens our community and our impact. Moving often taught me that simple gestures like a smile kept my siblings and me connected. Over time, I've come to appreciate how a smile can transform a room, making strangers feel loved, making strangers feel welcomed, colleagues feel seen, and friends feel loved. I want to end by celebrating all of you. The smiles, the support, and the graciousness I've experienced here at the Moran the last 3.5 years has truly been tremendous. Thank you for being part of my journey and for inspiring me every day. Special thanks to Barbara Cruz, Brandon Cresswell, Dr. Rachel Simpson, Dr. Jeff Petty, and Dr. Randall Olson for answering my many, many inquiries on some of the infrastructure that the Moran has currently in place. I invite everyone's thoughts and ideas on how we can further enhance our culture, what works for you, what doesn't, and how can we build on what we currently do. I'm also eager to hear if there's anything you might believe I have missed that can be pivotal to establishing this culture or sustaining it in the future. And I promise my last slide here. I want to leave you with this quote that resonates deeply with the spirit of our work in our community. To love someone is to learn their song and sing it back to them when they have forgotten. It reminds me of the incredible resilience and joy I witness every day in this community. There have been moments where I've forgotten my own song, but what your unwavering positivity and kindness have reminded me of it through and through. I encourage you to continue sharing your joy and positivity. You never know whose day you might brighten or whose spirit you might lift up just by being yourself. Thank you for all you do.
All right, thank you, Nnana, for this beautiful and very heartfelt talk. And last but not least, we have Dr. Sarath Pathuri, who's a PGY1 in neurosurgery at the U of U. He'll be talking to us about posterior cortical atrophy. And Sarath's most adventurous thing he's ever done was getting a license in paragliding.
Good morning, everyone. I'm Sarath. I'm an intern with neurosurgery. I got to rotate with you all recently in October and decided to present a case that I saw in your ophthalmology clinic, a lady that came in with insidious vision loss. And so just jump right into it. So we had a 62-year-old female that presented to neuro-ophthalmology clinic with visual dysfunction. And for the past 4 years, she began experiencing all of these symptoms. She had difficulty writing checks. She was reading books upside down without knowing it. And her grandchildren would tell her, "Oh, Grandma, you're reading a book upside down." And she had trouble playing board games with her. And this all began around 4 years ago. She even underwent cataract surgery prior to seeing us in your ophthalmology clinic about 6 months ago, and it really didn't do anything to improve her visual symptoms. Her past medical history, I'm not sure why I got cut off here, but it really involved nothing contributory to her vision loss. It had hypothyroidism, she had prior cervical fusion, and other non-contributing illnesses. Apologize for the slides, I'm not sure why, there's some formatting issues, but this is her ophthalmological exam. She had relatively normal visual acuity, not perfect. Both her pupils were reactive. She had no afferent pupillary defect. She did very poorly on her Ishihara's exam, which led us to believe that she had some component of segmental anagnosia. And her visual fields to confrontation revealed that she had a homonymous left inferior quadrant tenopsia. On slit lamp exam, there were no defects to her cornea. It was rather normal. She had lenses from her cataract surgery. And then on fundus exam, there was no pallor or edema for her optic nerve that was noted. And her OCT was showing normal RNFL. This was an integrative visual loss test that I did with her. I'll walk you through it, but essentially it was a question-based exam where I presented her a series of images and then documented her responses and then scored her. The first exam on your left would be the subtest 1, where if you look down below into the diagram there, you can see a fish with a bunch of lines crisscrossed all over it. So it's a masked form test where you have objects that are masked. And then I asked her, "What do you see?" And so, for example, 2, there was a pail. She said there was a potato, and I misspelled potato, but that's my mistake. But so she was just clearly getting a lot of these objects wrong. She was able to see. She would let me know that she could see what an outline. She could see an object, but she was just getting them wrong. So there's some cognitive component to this. In subtest 2. There were objects that were overlapped. So if we come back down to this reference diagram in the left bottom corner, you see a cat with a hanger and a plane on top. Similar to that, she was getting a lot of these questions wrong, and she scored poorly and didn't pass. She had 4 there, passing score is 7. In fragmented forms where images are fragmented, she couldn't really piece together what the entire object was and failed on this test too. And the last test was dashed lines. So here, the paper started off with a bunch of lines that were not crossed through, and it was her responsibility to cross through these lines. And she was only able to cross off about 31 of these lines, which is not a passing score for her. She was, if you look at this, there's entire fields in the paper where she didn't touch it, like the bottom left. And this is a integrated visual test that's been used throughout the literature and dating back to the 1981 for visual loss for cognitive reasons. Her Humphreys visual fields showed that she had a left homonymous hemianopsia, and this was repeated again. She had seen a prior ophthalmologist too, but it demonstrated that she had at least a defect on visual fields. And this is her MRI for brain. It's a T1 sequence. We're not really able to appreciate any lesions here that could explain why she's having an isolated defect that we did observe on visual fields. There's no mass effect from any lesion. There's no vascular abnormality. The flare sequences, the DWI, had no findings. So then we start building differential for MRI normal homonymous hemianopsias. And so one of the ones that was top on our differential is posterior cortical atrophy. But you can also find this finding in CJD, specifically the Heidenhain variant, which is targeting the preons posterior cortex specifically, where CJD can present in a lot of different forms. And but in this variant, the presenting symptom is usually visual symptoms. You can have MELAS, which is the mitochondrial disorder, stroke-like episodes that you can notice on MRI with flare changes, but you can also have MRI normal findings. Typically, these happen in patients that are younger, not in a 62-year-old female, and they're inherited in the mitochondrial pattern. Migrainosis infarction could also be on the differential. These are generally temporary or permanent, but she's had a 4-year history of these symptoms, and along with cognitive decline. So this would be a bit lower too. You could also have an ischemia or hypoxic insult to some of the optic tracts, the lateral geniculate or optic radiations. But we did not really see this on her MRI in terms of the DWI sequences. And so this would be lower on the differential too. Ultimately, she was given a diagnosis of posterior cortical atrophy. And I apologize for the formatting slide here. I'm not sure what's getting cut off. But essentially, this is a condition where there's degeneration of the occipital, parietal, and temporal cortices and leads to visual perceptual, visual spatial defects, and even apraxias. It's sometimes considered by some as an atypical variant of Alzheimer's disease. And if you do consider it such, this occurs at a frequency of 13% in the population. Typically, this posterior cortical atrophy occurs in patients that are younger, whereas Alzheimer's presents in patients that are older in their 7th or 8th decade of life. This presents in the 5th or 6th decade in life, and it's a clinical radiological syndrome, diagnosed both clinically and with findings of posterior cortical atrophy. Sometimes CSF labs in some studies have shown that there's decreased amyloid beta 42 levels in CSF, with elevated total tau or phosphorylated tau levels. On imaging, we see that in a control versus a patient with diagnosed posterior cortical atrophy, there's overall reduced cerebral blood flow in the posterior region of their brain. On PET scans, you can see decreased metabolism. You'll find atrophy on MRI. And then when you scan for amyloid, you'll find that there's deposition there too. So there was a meeting of roughly around in the 2010s where they're trying to come up with a diagnostic criteria for diagnosing posterior cortical atrophy. And basically, you have to have an insidious onset. There are some core syndrome features. You have to have an insidious onset. This has to be a disease that progresses gradually with disturbance of visual functions. And when you go down through the pathway of this, some of the presenting features that we saw in our patient was simultaneous anagnosia. She has object perception deficit based on the integrative visual screening test that I did. And she also had a homonymous visual field defect. And then when you work through this more, you have to, as the disease progresses, you can appreciate imaging defects such as hypometabolism, hyperperfusion on PET scan, atrophy on MRI, things like that. And then the other cognitive domains are generally intact in this disease, in at least the earlier stages of the disease. But as you progress and there's global atrophy, you can develop full-on Alzheimer's disease and have episodic memory loss and executive dysfunction. Some of the exclusive criteria would be obviously having a lesion, a vascular lesion or a tumor compressing a pathway and causing visual defect. So the overall framework to approaching a workup of posterior cortical atrophy is first establishing the syndrome, and that would include the timeline of the disease process. So has it been insidious in onset, gradually progressive, not sporadic like CJD? And if there's no other cause on imaging, tumor or vascular, then you can begin to consider posterior cortical atrophy, and you have a neurodegenerative disease going on. And then if it is preferentially posterior based on imaging, then it's likely posterior cortical atrophy. And then posterior cortical atrophy splits into having a pure manifestation or having a plus manifestation, where there are other components going on, like dementia with Lewy body disease. So some patients might present with visual hallucinations during sleep, disruption of their REM sleep cycle. We could have cortical basilar degeneration, which would be presenting with limb dyskinesia, rigidity, and other apraxias. And with prion disease, the classic startle myoclonus and other symptoms like that. There's no real good biomarkers at the moment that people have been using to diagnose this disease, and so it's clearly still a clinical and radiological based diagnosis. So this patient was ultimately referred for a formal neuropsychological evaluation. She was also offered cognitive neurology follow-up. And in the literature, there have been some attempts at treating this. Occupational therapy is frequently attempted. There's been a study that looked into using acetylcholinesterase inhibitors in patients with PCA. They split them up into two groups, and they actually found that the group that was treated with acetylcholinesterase inhibitors, 44% of them experienced nightmares in their sleep, whereas the control group 0% had no nightmares. And so there's some data to suggest that it might actually be disadvantageous. And overall, this is still an active area of research, trying to diagnose this condition in a timely manner, because the onset is so insidious, and there's not always a radiological finding in the earlier stages of this disease. So patients are frequently misdiagnosed. And that was this case that I saw with Dr. C. So I'm really thankful to have gotten your help on putting these slides, and I really apologize about formatting. It was perfect on my laptop, but everything's been chopped. Yeah,